I'm just sort of reflecting on the conversation so far this evening, and I have to say it just puts me in mind of a conversation that I had with a colleague of mine at Capital Health a few years ago, Dr. Brendan Carr, who was our VP of Medicine and has since moved on to BC. And Dr. Carr was one of my teachers when I was a student at Dalhousie University, and I found myself in the fortunate position of having him as a colleague later on in my career. And Brendan used to lovingly refer to those of us in public health as you fringe people. That left-wing arm of medicine, it's out there doing all that crazy population health stuff. And we would have a good joke about that. And I find myself today sort of remarking on the fact that I seem to be sitting in a room full of fringe people. And it doesn't feel so fringy. It's kind of nice. I feel like I'm home. So I'm very grateful for that. So what that means is that I don't think I'm going to tell you anything that you don't know already, but I am going to try and sort of bring home for you how at a local level here in Nova Scotia, some of these things that we're talking about are actually playing out in real time, real community conversations. And I think we've already had some good examples of that today from Gaysborough and Antigonish Strait Health Authority as well, and the work that's happening here in Antigonish. So this is just adding to the picture. So as Connie described, you know, what the relationship that we have with the NCCDH in Halifax is actually that we've been fortunate enough to find ourselves in a wonderful little project with the NCCDH around looking at health status reporting and how do you make that health equity focused and look at sort of root causes of health outcomes in that process. And along the way, we've been talking about this list that's up there now, which is the 10 promising practices to reduce social inequities in health. It comes from the Sudbury Health Unit in Sudbury, Ontario. Sudbury found themselves looking at this as part of what's known as an extra fellowship from the Canadian Health Services Research Foundation a few years ago. Canadian Health Services Research Foundation is essentially a foundation that is committed to sort of academic and scholarly pursuits in improvements in healthcare systems. And so the medical officer of health, my counterpart in Sudbury, actually went through that program, and as a result of that program, developed this list of what has now become considered here and around the world as sort of promising practices in reducing health inequities. I'm not going to talk about the entire list, but I'm going to talk about 3 in particular that I wouldn't say we've been consciously following the roadmap that was laid out by Sudbury in our work, but as we reflect on our work now, in Capital Health, what we see is that the promising practices that Sudbury discovered, in fact, hold true for us. And so I'm going to focus on purposeful reporting, community engagement, and intersectoral action as the ones I'll talk about today. And the entire list, including some great fact sheets on each of the promising practices, is available on Sudbury's website. So our story in Capital Health, I'm going to harken back to the beginning of the evening, actually, and some of the comments from Dr. Strang, who is my boss in the Nova Scotia Public Health System, but was also my predecessor in Capital Health, and in many ways sort of paved the road for where we are today in Capital Health. Rob talked about our public health renewal process. It started in 2006 with an external review by Dr. Brent Malofny, looking at SARS and the impact that that had on the public health system across Canada, and specifically looking at what we should learn in the province of Nova Scotia from that. And after Dr. Malofny's report in 2008 in the province of Nova Scotia, we did something very significant, which is we took an opportunity to actually stop what we were doing. We used a theory called Theory U, a process essentially of deep critical thinking, and engaged in a series of public communications and public dialogue around what does a highly functioning public health system look like. And in order to engage in that conversation, we had to do a number of things across this province, including ask some critical questions of our colleagues and our communities and our partners. And I don't know if any of you are in this practice, but it's a little bit like that practice of stopping with your brother, your sister, your parent, your partner, and saying, as a sister or spouse or child, how am I doing? Am I all you thought I would be? Is it going okay? And you know that because you've got that relationship, they're going to tell you. And that's exactly what we got from the public in Nova Scotia. They told us. Our partners and the public told us what they needed. And out of that came the 6 stakes, of which health inequities was one. We clearly heard from the public and our partners that we needed to get grounded in a conversation about health inequities. But most importantly for me, and the launch point for our story in Capital Health really became this. So what came out of that process, which took us about 2 years, was a purpose statement for the provincial public health program in the province of Nova Scotia. And what this statement says is public health works with others to understand the health of our communities and acts together to improve health. This may seem like a small statement. This was land-breaking for us in Nova Scotia. And the reason for that was that this tiny word, understanding, uncovered a whole lot of what we needed to be doing in public health. And so the definition that we took on for understanding actually very concretely has its foundation in public health sciences. It is around surveillance, evaluation, epidemiology, and research. And this is work that we had not been doing well in the province of Nova Scotia. And this strategic planning process that we did in 2008 gave us permission to start doing it differently. What that meant for us in Capital Health was that we understood a few things. The first was, and this is around that promising practice from Sudbury around purposeful reporting, understanding needed to be the driver of all our work. And so this is a quote from our director and my co-leader in public health, Linda Young, who's the director of public health in Capital Health. And Linda's known around the building for saying this: understanding must be the driver of our work, and work that is not sustained by understanding, we really need to critically question. And so that meant that we were going to bring our best surveillance, epidemiology, evaluation, and research tools to the table. We're going to start using them to tell a story of what was happening in our communities. So that brings me to the second point, which is what we understood at that time is that geography matters in describing health outcomes. And by geography, I don't mean national geography. I don't even mean provincial geography. I don't even mean regional geography. Geography of individual communities matters if you're going to tell a story about health disparities and health inequities. So we had a sense of how we might go about doing that. And what we realized was that our entry point in public health into any conversation about health inequities or health disparities is going to start with a look at health outcomes. And so we knew that what we needed to do was look at health outcomes. But as you saw in the video from Antigonish, which I love, ours in public health is always to ask the question, why? If there is a difference in health outcomes between one group and another group, why is that there? And by asking the question why, we get to look at what were the risk factors that caused that differential. Our questioning is not done there. So the next why has to lead us into a conversation about what are the conditions in communities that predispose to those risk factors being there, that predispose to that differential in health outcomes. And when we look at communities, we start to see how communities are fostering inequities. And there's actually methodology that you can use to do that. So we had a notion that we could use this methodology, the deprivation index from INSPQ, which basically is a measure, it's a methodology to sort of assign a measure of material and social deprivation, not a great set of terminology, deprivation, but to look at social, sort of haves and have-nots and material haves and have-nots in any community and assign basically an index to that that allows us to compare communities to one another and see how they're doing. So we had a sense, because we had been engaged through Rob's leadership prior to me in some work that CIHI had done around looking at health inequities in urban centers. We knew that we had an opportunity to reprise that work and look at it again. And so we decided to take that on. It has been absolutely fabulous for us. So one of the things we've been able to do is, in fact, reprise the INSPQ index for CDHA. We now use this type of mapping regularly. And so this just shows that we do, in fact, have differentials in deprivation within Capital District. Prior to this, we were looking at Capital District as a whole, and every time we looked at the whole, we would say, well, on the whole, we seem to be doing not too bad. But when you look by community, what you actually see is, well, some communities are doing really well, and some are not. And ours is to ask the question, why? That's the work of public health that we weren't doing, that we woke up to in 2008. Not only is it important for us to look at this by community, but in fact you can look at a smaller area of geography called dissemination area, and there you see that around the Halifax Harbour, so sort of the core of Halifax. In fact, there are even more inequities. So just because you're in the urban core doesn't mean that you're protected from those inequities. They exist even there. And so what we're now trying to do is uncover what are those health outcomes, how are they showing up as health inequities, and that starts the conversation for us. So that's sort of our learning around purposeful reporting. That's the intent behind our population health status report, is that we'll be able to put some of that type of information out there. The second set of learnings that I want to talk about briefly is around this notion from the Sudbury practices around community engagement and intersectoral engagement. And so as we go through this process, what we're learning is that bringing that data of a disparity that is happening, not even an inequity, just acknowledging that a disparity in health outcomes is happening is enough to open a door and start a good community conversation. An example of this for me comes from a few years ago when I found myself with a smaller set of data on a larger geographic breakdown, so by our 7 community health boards and Capitol Health. But I found myself in a conversation with the municipality and several other stakeholders, but 60 stakeholders gathered in this room to talk about injury prevention in the city of Halifax. And we were asked as public health to bring some data. And, you know, prior to 2008, I'm not sure the folks would have expected public health to come to the data. Dr. Carr would have said that public health would have come to the table with lots of philosophy. But it was nice for us to be able to come to the table with science and evidence and data to support the conversation. And what was interesting about that conversation was when we walked into the room, which it was attended by police officers and firemen and counselors and local NGOs involved in injury prevention and the business community and the education system, folks seemed to have a sense of what the issue was going to be around injury prevention. And the issue was going to be that we need to deal with violent crime on Halifax Peninsula. That's it. That's what we need to do. And so we're going to spend the day talking about that. When we actually looked at our injury statistics, what we saw was that there were differentials in outcomes across the city in terms of injury, but the highest injuries were not happening on the peninsula. They were happening in our rural communities, and it wasn't due to violent crime. It was actually due to motor vehicle accidents. And it was happening primarily in elderly people. So the interesting thing about that is that if you stop the conversation there, you can have a good conversation about just that piece of information. But if you stop the conversation there, you may actually miss the why of what's happening. So as we got into this conversation over several weeks with counselors from those rural communities were quite concerned. And what they would say to us is, well, why is this happening? And another counselor would say, well, clearly it's because they're elderly. I mean, maybe what we should do is actually see if we can pull their licenses somehow. And then somebody else would say, well, hold on a second. These are women. This was primarily women that this was affecting. So we have elderly women in rural, isolated communities. What if it's that there's nobody else to drive them because their husbands have died and there's no resources in their community? Then pulling their licenses probably isn't going to solve anything, right? What's really going on here? That's a conversation worthy of public health and community engagement. That's a conversation about inequities. And that's how data can open the door to that conversation. So that brings me, really to my last point, which is that, and this is a quote from a colleague of mine who's the medical officer of health for the city of Montreal. Montreal has done some fabulous work around mapping this, particularly around mapping of this sort, particularly around injuries. And Dr. Jouin, at a meeting that I was at with him a few weeks ago, actually, ended his presentation on the latest maps from the city of Montreal with this quote, that our job in public health is to bring that data to the table so that we can start a community conversation about it. And that data has to be about disparities. We have to be prepared to uncover there is something happening over here that was not happening over here and ask the question why. So that's the work that we're doing right now in Capitol Health.
Well, thank you very much, Connie. And on behalf of St. FX and on behalf of Dr. Riley, I want to thank everyone here for coming. I've got a list of individual thank yous for the people that have helped us think through these huge issues, but I want to thank everyone from the community, from the university, the students, the faculty, the staff of the NCCDH, everyone. I just want to say that St. FX is absolutely proud to be the host of the National Collaborating Center for the Determinants of Health. I want to thank everyone who has contributed to that. You know who you are, faculty members, staff members, everyone. I want to thank everyone this evening, in particular our presenters, for these huge insights into the need for attending to the big drivers influencing health and helping us illuminate the causes and showing the path that is needed to mobilize change.